Hi, everybody. We'll get started in just a moment. Just going to make sure everybody gets into the webinar. Okay, I think we'll go ahead and get started. So good afternoon, everybody. I'm glad you're able to join today. I'm Allison Foster with Delta Omega and happy to be hosting today's presentation. So hopefully you know that Delta Omega is the Public Health Honorary Society. We were founded in 1924, which means this is our 100-year anniversary. There's currently over 130 chapters of Delta Omega at CEEP accredited schools and programs, and collectively they've inducted over 30,000 members. So because we're having an anniversary, one of the ways we wanted to celebrate this year is to host a series of webinars looking back over the past 10 decades. So today's presentation is from the Child chapter at the University of South Florida College of Public Health on public health in the 1980s, from bleak to bright, a review of HIV/AIDS in the United States from the 1980s to today. So the two presenters today will be Dr. Allison Oburn, who's the president of the Tau chapter, and Brooke Yost, who's an MS-PH candidate. So I'm going to go ahead and turn it over to them. If you have questions, and I hope you do, go ahead and put them in the Q&A, and then we will take all the questions at the end. Thank you very much. Go ahead, Dr. Oburn.
Thank you so much, Allison. It is lovely to be here today. I am really excited. When we started the planning process for the 100-year anniversary and the webinar series, I was thinking about what topic to pick, and the Tau chapter of Delta Omega began in 1987. And so it wasn't too hard to think about what were some major events and issues that occurred in the 1980s. And so we really landed on HIV and AIDS and the epidemic, and wanted to think a little bit more, though, about how we can put this into perspective, and how, although things might have been bleak in the beginning, there is a brighter outlook and opportunities for a brighter future. And so I'm excited to have you all join us today. So I wanted to start with a little bit of an overview of our presentation. So first, we are going to talk a little bit about what HIV was like in the 1980s and how we really saw the onset of the epidemic. And we're going to transition into an evolution of HIV in public health and medicine. And then we're going to talk about initiatives to support HIV awareness, prevention, and treatment. And then, of course, leaving plenty of time to have a discussion. I think there's so much that we can talk about, and so many really fascinating new avenues for us to explore and really think about the last 40 years with regards to HIV. So I am happy now to turn the presentation over to Brooke.
Thank you, Dr. Oburn. All right, so sorry about the echo. To begin the first part of the presentation, we will go into the initial identification of HIV in the United States. It all starts on June 5th, 1981, when the Centers for Disease Control and Prevention published the Morbidity and Mortality Weekly Report detailing 5 cases of pneumocystis pneumonia in healthy gay men. So these were men who were previously healthy, did not exhibit any symptoms, just suddenly had this opportunistic infection. And this indicated that there was a problem with their immune system. And this all occurred in Los Angeles, California. Meanwhile, across the country, shortly after, a New York dermatologist reported a cluster of Kaposi's sarcoma, so a rare cancer, in 41 gay men. Suddenly, there appeared to be a spread of rare cancers and opportunistic infections in this specific group. Now, towards the end of 1981, in December, there were 5 African-American infants who displayed symptoms of immune deficiency, and this was similar to what was seen in the gay men. And this was noted by Dr. Rubenstein. Although the symptoms were similar, the similarity was dismissed at the time. And it's important to note that most of the infants had mothers who were sex workers as well as used drugs, two things that we later linked to being at risk for HIV. So at the end of 1981, there were 337 reported cases of this severe immune deficiency. And of the 337 cases, 130 of those cases had died by the end of 1981. Moving forward, on July 16th of 1982, a morbidity and mortality weekly report was published detailing 3 cases of persons with hemophilia who displayed symptoms of immune deficiency. This presented a new group of people who appeared to be at risk for this new viral disease. Later that year, on September 24th, acquired immune deficiency syndrome was used for the first time by the CDC, and an official case definition was released to classify these cases. It would not be for another 4 years, however, that the new virus was officially named HIV, or human immunodeficiency virus. Now, by the end of the decade, in 1989, there were 100,000 reported cases of AIDS in the United States. So as you can see, it took a while to even develop a case definition and a name for this virus. Meanwhile, there were several people in at-risk groups who were having these rare cancers and opportunistic infections. So moving on, we're going to talk about the stigmatization of at-risk groups. The early HIV/AIDS epidemic could be characterized as surrounded by fear and uncertainty. From that fear came stigmatization and discrimination of these at-risk groups. The public and doctors weren't sure exactly how this disease spread. So assumptions were made on who could be affected and how to interact with those at risk. The early public perception was that the disease could only affect gay men. This was emphasized by newspapers who referred to the disease as a gay disease. The Bay Area Reporter was the first to use the term gay man's pneumonia. Shortly after, New York Times reported cases of gay cancer, and were the first to refer to the disease as gay-related immune deficiency, or GRID. And this term was actually adopted by a couple physicians and researchers who would refer to this and keep perpetuating that idea of that this is a disease that only really affects homosexuals. All of these terms published in the widely read newspapers, as you can see, the New York Times, only deepen that assumption that only gay men were at risk. From this, similarities in cases between gay men and other groups were dismissed. As I mentioned earlier, the AIDS diagnosis in infants were not definitive, because how could these newborns have gotten a disease associated only with gay men? We also know that females were at risk, but we don't see a lot of mention of them as far as regulations go or prevention methods. It really is all focused on this specific group. A LA Times poll states that most Americans think that AIDS patients should be quarantined. So people are afraid to even touch or be around those with HIV because they're not sure how the virus is spreading. We know now that it's spread through bodily fluids, but at the time they weren't sure if it was through contact, if it was airborne. They just didn't want to be around this group that could be categorized as unclean or infectious. It was just a lot of fear and uncertainty. This led to people with AIDS diagnosis to be barred from entering spaces such as schools or workplaces. I wanted to highlight specifically Dr. Joseph Sonnabend, who was a doctor who treated AIDS patients, and he and his patients were threatened with eviction from his workplace. So this led to the first AIDS discrimination lawsuit, which he did win, thankfully. But it just goes to show you how people really didn't want those with an HIV/AIDS diagnosis around them. Now, HIV was listed on the United States Immigration Exclusion List, and all applicants must be tested. This meant that an immigrant tested positive for HIV, they would not be able to enter the country. The exclusion no longer applies, however, it's a prime example of these discriminatory policies. Finally, the FDA instituted a lifetime ban on men who have sex with men, or MSM, from donating blood. Since there were cases of blood transfusions infecting individuals with HIV, MSM could not donate blood as they were the group with the highest number of HIV cases. This policy ignored the fact that women could also get HIV and could potentially infect others through blood transfusions. And that was established as early as 1983. It also banned gay men with one partner who may not be engaging in that risky sexual behavior. They were all lumped in as one group. These examples of stigmatization led to feelings of isolation and created an incentive to be silent about HIV diagnosis out of fear of discrimination. Right, next slide. I wanted to highlight this poster in particular. This slide demonstrates the lack of awareness of transmission and the fear of HIV. And the poster's from 1987, and it reads, "I have AIDS, please hug me," with a cartoon individual looking fairly distressed. The poster was meant to emphasize the feelings of isolation that may have been felt by at-risk groups who were discriminated against and convey that the virus can't be transmitted via touch. At the bottom, there's a hotline for kids with AIDS, as HIV positive children were also excluded. So they may not have that tactile love or friendship just because they were diagnosed with this virus. So let's go over the means of transmission. In 1982, there was a connection made between sexual transmission and the recent outbreaks of rare cancers. We know now that bodily fluids are the primary means of transmission. There are sexually transmitted bodily fluids such as semen, vaginal secretions, and rectal fluids. Non-sexually transmitted bodily fluids include blood and breast milk. HIV can also be transmitted from an infected mother to her child during delivery. That's how we were seeing those infant cases of HIV. We also have workplace exposure that includes blood transfusions or blood-related based exposures. For example, if a healthcare worker is accidentally exposed to infected blood from improper cleaning procedures, or they have contact with an accidental needle stick. Finally, we have injection drug use and needle sharing. Among drug users, that can be a means of transmission. If one infected individual shares their needle or improperly discards the needle, this could be a way that other people get infected. So each of these routes of transmission have their own unique methods for prevention that we'll cover a little bit shortly. We now move on to the evolution of HIV/AIDS in public health and medical communities. This is stepping away from history and now looking at it more in a modern context. Over the course of the epidemic, 700,000 Americans have died of AIDS-related illnesses, and there have been 36 million deaths worldwide. 1.2 million people are currently living with HIV in the United States, and 36 million people internationally are living with HIV. While AIDS may not be a death sentence anymore, it is still a major public health concern that we must address. So the first test to detect HIV was the ELISA, which was approved to detect HIV in blood donations in 1985. So only 4 years after the epidemic really started, we had our first antibody test. The primary purpose of this was to screen incoming blood donations for HIV to try to prevent infection through that route. And then with the ELISA came the antibody test, which can detect HIV 18 to 45 days after exposure. The process involves blood drawn from a vein, and it must be done in a lab. Another lab-based screening technique is the nucleic acid test, which can detect HIV 10 to 33 days after exposure. And the benefit of this test is it can detect infection earlier than any other HIV test. Now, something I want to highlight is that both of these must be done in a lab. So that involves people getting out of their house and going to a different building. Now, with the stigmatization and the discrimination of people with HIV, it might be a little scary to have to go to another building to possibly be seen or questioned on what they're doing there. If a coworker or a friend sees you and you say that you're there for HIV testing, that could then lead to some stigmatization. So while we may not see that as much today, those early tests, I can definitely see a decreased incentive to want to go get tested because of that. We do have the rapid antibody test, which became widely available in 2012 and to 2013, which can detect HIV 18 to 90 days after exposure. The process involves blood drawn with a finger stick instead of from a vein, although some tests can use saliva as well to detect HIV. The rapid test, OraQuick, involves swabbing the upper gum and can actually have a test result 20 to 40 minutes after swabbing. We also have antibody tests, which have a slightly later detection period of 23 days, but it can still detect antibodies up to 90 days after exposure. Now, self-test kits have become widely available since 2012. These were especially useful during the COVID-19 lockdowns, as individuals could just order them to their house without having to leave and go to a pharmacy or go to a lab. These self-test kits, like OraQuick, can give individuals a rapid result within the privacy of their own homes. So this is important to highlight because, as we covered earlier, the stigmatization of at-risk groups, self-test kits can give patients an opportunity to not have to go out and be seen. It can provide them with that privacy and a little bit more security. But we will dive more into the pros and cons of self-test kits later with Dr. Ober. Now we're going to discuss prevention. So early prevention strategies included educational material on safe sex practices and symptom identification. Since there was not much known about how the virus spread, the distribution of educational materials was an inexpensive way to prevent infections. They knew that sexually active gay men were at risk, so ensuring that they knew what symptoms to look out for was critical. They may not have known how it was being transmitted, but like I said, there was that link in 1982. So getting that educational material was inexpensive and easy to distribute. There was also the closure of businesses where risky sexual behavior takes place. And these included bathhouses, bars, and clubs, specifically gay clubs. This was actually found to be ineffective and was ruled against in a lawsuit in California. And bathhouses, bars, and clubs were allowed to be opened or reopened, remained open. And these places were actually a location where educational materials could be distributed. They were hubs where signs, pamphlets, discussions could take place to provide those prevention materials. So closing them down wouldn't have been effective because the activities were likely going to continue. For example, risky sexual behaviors were likely to continue in other places. The building didn't really matter. We also have antiretroviral therapy, or ART. This is a useful prevention method, as we'll go into later, but it reduces the virus load in the body and I will talk about it just a little bit more later. We also have safe sex practices, and these include condoms as well as regular testing. So the use of condoms will prevent that bodily fluids from being exchanged. And regular testing, if you have multiple sexual partners, is super important to make sure that you're not transmitting HIV, as well as someone you may have slept with does not also have HIV. So knowing your status is super important to preventing HIV. The use of clean needles for injecting drugs is also very important. So this is going with the people who are at risk who use injection drugs. So moving to a different group, we have needle exchange programs, and they're gaining popularity, but they're still surrounded by some controversy. We'll go over that as well a little bit later with Dr. Oburn. But the use of clean needles is very, very important to making sure that this group does not spread HIV. Finally, we have screening blood donations before transfusions. So like I said, this was available with ELISA by 1985, and it's still a useful tool to make sure that all blood donations are not infected with HIV before they're transfused into a patient. Right. Finally, we have treatment. So there is currently no cure for HIV. This is unfortunate, but there is symptom management of opportunistic infections such as pneumonia, but there's no cure for the underlying infection of HIV. While it may sound hopeless, ART can be used as a treatment for HIV. This is a medication that must be taken every day. It can lower the amount of the virus in the body and simultaneously helps to fight other infections. So not only can it help lower the HIV, but it can also help fight those opportunistic infections. It also strengthens the immune system by preventing the virus from replicating in the body. So that is the chief role of ART, is that it prevents that replication, so we actually see the viral load go down. And there are several different brands of medication, and they each depend on the patient's CD4 count, the method of fighting the virus. So each might target a different protein, as well as drug interaction. So if the patient is taking other medications that may interact with the ART drug. Each treatment includes 3 HIV medicines from at least 2 different HIV drug classes, and the drugs can actually be combined into one pill. Although some individuals might have to take 2 to 3 pills to achieve the total effect. So ART is extremely beneficial to those living with HIV. However, it's important to know that individuals will be having to take this medication every single day for the rest of their lives. So it will be useful to still research and look at different ways that we can treat this disease and hopefully one day find a cure for it, if we remain hopeful. But with that, I will turn it back to Dr. Oburn to discuss HIV initiatives.
Thank you so much, Brooke, that you gave us a really wonderful overview of kind of the history of HIV, helping us to understand treatment and prevention. And what we're now going to switch into is more of a conversation about initiatives and what different types of initiatives exist to support HIV awareness, prevention, and treatment. So first, when we think about influential individuals, or excuse me, when we think about HIV awareness, we might think about people who have helped us to really understand the scope of the problem. We might think about newspaper headlines and really giving a face to the HIV epidemic. And so I've chosen to highlight 3 different individuals. These folks may or may not be familiar to you. The first person is Bobby Campbell. And Bobby Campbell was a nurse working in San Francisco, and he was diagnosed with Kaposi sarcoma in 1981. And he became a social and political activist and really the face of HIV. he became the first Kaposi sarcoma patient to go public and even called himself the KS poster boy. He posted photos of his lesions to help alert the community. He wanted to make sure that individuals really knew and understood what some of the symptoms might look like, and he encouraged people to seek treatment. So, a really prominent figure in the initial understanding of HIV. And the second person that I want to highlight is Ryan White. And Ryan White might be a name that you are familiar with when we think about the HIV epidemic. And we had originally thought, oh my gosh, it is right. It was that GRID, it was that gay related infectious disease. And then we started to realize, no, it really affects many, many more individuals. So Ryan White, young boy, suffered from hemophilia, and as a component of his treatment was required to get blood transfusions. Well, in 1984, he, at 13 years old, was diagnosed with HIV as a result of a blood transfusion. After being diagnosed, he was barred from going to school. Right? He lived in a small town in Indiana and just wanted to be a kid and wanted to go to school. And really, he and his family had to fight for him to attend school. And this really gained national attention. And as a result, he really became the face of public education about HIV because it spanned broader than just a smaller segment of the community. And then the last person is Magic Johnson. And, when we first think of Magic Johnson, we might have originally thought of his notoriety as a pro basketball player, right? That all changed in 1991. He announced his HIV positive status. And this really served as a catalyst for bringing HIV into the forefront of the heterosexual community. Prior to that, we really hadn't seen as much emphasis on HIV among other groups of Americans. And so, what happened here is we started to see greater amounts of HIV testing among other groups of individuals, which could really lend to earlier treatment. Since then, Magic Johnson has been a powerful public figure, increasing awareness and resources for HIV prevention and treatment. Well, we've got some faces, right? We know people who are really influential, but now we need some money. So we need some opportunities to try and make a difference. And having resources can be really critical for prevention and treatment. So here we see, again, just a snippet of some initiatives that have been implemented over the past 40 years that I wanted to highlight. The first was in 1983, and this was when Congress passed for the very first time a bill to support funding specifically earmarked for AIDS-related research and treatment. And this was $12 million that would be spread to different agencies covered by the Department of Health and Human Services. Now, in 1985 is when the FDA established their ban for men who have sex with men in engaging in blood donation. And Brooke had mentioned this earlier, right? So we talked about Ryan White, right? How he had contracted HIV through a blood transfusion. And so now we're seeing a federal ban on individuals being able to donate. Move now into 1990, where Ryan White became recognized in a formal legislative act. So Congress passed the Ryan White Comprehensive AIDS Resource Emergency Act. And through this act, HRSA manages the program, and it's the largest HIV-specific federal grant program in the United States. So providing a lot of resources and services to communities throughout the United States to support HIV prevention and treatment across the spectrum of the HIV and AIDS continuum. In 2003, George W. Bush announced in his State of the Union address PEPFAR, and PEPFAR is the President's Emergency Plan for AIDS Relief. And this has provided since 2003 over $100 billion in global HIV and AIDS response. What does this break down into? Over 25 million lives have been saved. Over 5.5 million babies have been born HIV negative to mothers living with HIV. And we see over 20 million people are provided with ART across 55 different countries. So this has had a really significant impact in the last 20 years. In 2010, we had the historic passing of the Patient Protection Affordable Care Act by President Obama. And this really increased accessibility and affordability to healthcare services for Americans. What I think makes it important when we think about the context of HIV is that it provides a lot more testing and treatment for individuals who might be diagnosed with HIV. We know that prior to the Affordable Care Act being passed, individuals could be denied health insurance as a result of pre-existing conditions. And so this removed that exclusion so individuals could make sure that they don't have a lapse in coverage. Then we're kind of going back to this discussion of the FDA, right? So in 1985, we have this ban on any man who has sex with men being able to donate blood. Well, in 2015, we had a little bit of a change to this policy. And the change was that men who have sex with men can donate blood if they do not have sex with a male partner in the last 12 months. So it's almost like you can donate blood, but you have to be celibate in order to do that. Well, that doesn't seem very realistic to have an expectation of, individuals to, abstain from sexual acts. So this actually stayed for about 8 years. And then at the end of 2023, FDA had a full removal of the ban. So now any man who has sex with men, however they identify, are able to donate blood. So that's a really huge transition that we've been seeing over the years with regards to funding opportunities and legislation to impact HIV reduction and resource allocation. But we know that government can't do everything alone. There are a lot of roadblocks, there's a lot of challenges, and we need resources and we need boots on the ground. And so here's where I think advocacy and grassroots efforts are really critical to reach communities across the United States. There are hundreds of different organizations that really focus on allocating resources to individuals who are at risk or who are living with HIV. And I have just a couple listed here, and I'm just going to highlight 2 of them for us. The first example is the WELL Project. And the WELL Project is a nonprofit organization focusing on girls and women who are at risk or living with HIV. And what I really loved about their mission is that it's not just focusing on helping them to survive, but really looking at thriving. How is it that individuals can be provided resources so that they can thrive despite having an HIV positive diagnosis? And then I also wanted to highlight Housing Works. So Housing Works fights for funding and legislation to assure that people who are living with HIV have access to quality housing, to healthcare, HIV prevention, and treatment. And they've provided resources to over 30,000 New Yorkers who are living with or at risk for HIV infection. Okay, so what are some other treatment resources that we have seen? I've got some acronyms that I want to share with us. So the first one is U equals U, and this stands for undetectable equals untransmittable. So in other words, we are able to see that people who are living with HIV who maintain an undetectable viral load, which means less than 200 copies per milliliter of blood, cannot sexually transmit the virus. So in order to become undetectable, what do we have to do? We have to consistently take ART to suppress the viral load. So it's making sure people get early and consistent treatment in order to suppress that viral load and make sure that they are staying healthy. So early detection actually can help to support prevention of future infections and reduce an AIDS diagnosis among people who are living with HIV. So this was a really, I think, monumentous recognition within research and then translating that into the community. I also want to talk about PrEP and PEP. So PrEP stands for pre-exposure prophylaxis. And the goal of PrEP is to really provide HIV prevention to individuals who are at risk for contracting HIV. So this might be individuals who are at risk because of sexual partners or through IV drug use. So this might be individuals who are having multiple sexual partners, might be in a monogamous relationship with somebody who's HIV positive and does not have a suppressed viral load. It might be somebody who is using IV drugs, but has a needle sharing partner or is just sharing needles with other individuals. And what they're going to do is they're going to take HIV medication. So this is very similar to the ART that Brooke talked about. So some of those medications might be Truvada, Descovy, or Apretude. So it might be in the form of a pill or a shot where individuals work with healthcare providers in order to assure that they can continue to maintain an HIV negative status. There's been a lot of really wonderful outcomes associated with the use of PrEP, where we see that individuals who are consistently and correctly using PrEP see a 99% risk reduction in sexually transmitted infections and a 74% reduction in drug injection transmission. So PrEP can be a really wonderful approach, making sure that we are protecting individuals who might be at greater risk. Now, there's also PEP, and PEP is post-exposure prophylaxis. And this is, again, antiretroviral medications. The difference here, though, is that we're taking it after exposure. So what is most important here is timing. We need to make sure that individuals are getting access to PEP within 72 hours of that exposure. So time is really of the essence. With PEP, this might be somebody who had a high-risk sexual encounter. For example, they had sex with a new partner and the condom broke. It could also be individuals who share needles with someone, or if somebody had been sexually assaulted. We can also see workplace-associated exposures if we're looking at, for example, somebody in a workplace. Brooke had mentioned earlier if we saw needle sticks or if we saw any sort of maybe exposure to blood products. So that could be a potential risk factor where individuals might need PEP. Now, if somebody is regularly taking PEP, then they will often switch into the PrEP mode where they start to engage in preventative rather than post-exposure interactions. And of course, with both of PrEP and PEP, we're still encouraging consistent condom use, and we're always going to encourage testing. We want to make sure that individuals are getting access to information to help them understand their status. Now, as far as future directions, some of these are in process right now, right? So when we think about the future, we're living it. And so one of them is needle exchange programs. They're also called syringe service programs. And when we think about these types of programs, we're really focusing on individuals who are at risk because of IV drug use, right? So we often talk in public health about harm reduction strategies. We might not be able to stop a behavior, but can we reduce harm in some way and limit maybe one negative component? So we might not be able to eliminate IV drug use, but maybe we can reduce infectious disease transmission through needle exchange programs. So by providing individuals with clean syringes, they can be less likely to have a bloodborne infection, whether it's HIV, whether it's hepatitis, or a variety of other bloodborne pathogens. Through these needle exchange programs, we're also able to provide resources. We can provide information for people to understand risk associated with sharing needles and about drug abuse and treatment opportunities. We have controversy with this, right? Of course, harm reduction can sometimes be a little bit tricky, and some people have a lot of concerns that by providing clean needles, what we're actually doing is increasing drug use and not limiting harm. Good news is we have a body of evidence that proves that is not necessarily the case. The CDC has reported that participating in these needle exchange programs actually leads to a 5 times increase in individuals initiating drug treatment programs. And so we can actually see a lot of really positive outcomes associated with these needle exchange programs. I think one of the biggest barriers that we face with this, though, is legislative action. So although many states have approved these syringe service programs, they don't necessarily have the capacity to implement them. And there might be barriers within local jurisdictions. So the state might approve it, but the county doesn't approve it. And there's no funding associated with providing these clean needles. So there are still many barriers to continue to work through. And then we also have self-testing. And so Brooke had mentioned previously that there are a variety of different types of tests that people can use in order to detect viral load. And so we talked about, antigen tests and antibody tests. And one of the wonderful innovations is self-testing kits, right? So OraQuick being an example of that, where you can just do that salivary screening, and you can do it at home, right? In a private environment where we don't necessarily have that concern and that fear of being in a public area or being associated with going into a testing facility or clinic. Some potential cons: cost, unless somebody chooses to get it through a nonprofit organization or through a community agency, they might have to pay. There's also concerns that, of course, not every test is going to be perfect. We've seen this in the past several years through a variety of, COVID tests, for example. But when we think about these tests, it's possible that we could have false negatives. We might have tested too soon and somebody's still in that window period. And so we're really not capturing an infection that could be still developing. Unfortunately, there are some rates of false negatives as well that can be concerning. And so, just because somebody has one negative test doesn't mean that that is a green light to engage in any risky behavior. And then I think that what is also really important to consider is if we're doing at home tests, how can we make sure to continue to assure that there is health education and counseling that's being provided to individuals? If somebody's doing an at home test, regardless of the outcome, whether it's a negative or a positive test, those are great points of intervention to talk about what are strategies that we can engage in to prevent a future positive test, or how can we continue to maybe process some of these types of outcomes or findings. So I think that there is still some work to be done here, but I think it's really exciting that we have a lot of opportunities to increase awareness and accessibility and decrease stigma, because stigmatization continues to be a challenge. Hopefully, we have heard a lot of information that may have been new or might resonate with what you've already learned about the HIV epidemic. A lot has happened in the last 40 years, and I'm sure there's a lot still to come in the future. But we are hopeful. We are hopeful for a brighter future. And now we would love to open up the floor to any questions or discussion that anyone might have. We do have some guiding questions to help support a conversation, but we are also open to other topics that those of you might be interested in discussing. And thank you so much for joining us today.
All right. So yes, thank you so much. That was a terrific presentation. Found a lot of things that I learned myself. So do you want to take any of these questions that you've shared here, and we'll see if there's any others from the audience?
Sure. I'm going to turn things over to Brooke to see if you wanted to talk a little bit about some of these issues. I didn't see any questions come through unless that's just me not knowing always how to navigate Zoom.
I can I can weigh in just to kick things off a little bit. So I talked a lot about the stigmatization of at-risk groups. So I just wanted to highlight that second question that we have there, which is, to what extent do you think we have destigmatized HIV and AIDS in society? And I'll kick things off with discussing it a little bit. So something I have seen a lot of is commercials, billboards, just driving down the highway. I see a lot of these very colorful neon signs that are talking about PrEP and HIV prevention. And a lot of the people who are in those advertisements are smiling or engaging in a activity like sports, or they're seen with their partner. And I think that's super important to highlight, because we've associated this disease with a lot of death and a lot of unfortunate events, but framing it as, not that death sentence anymore, and showing those gay relationships or those lesbian relationships, and showing all of those different sexualities, and that it's all coming from a place of love. I think that's super important to reducing that stigma within society, is how we picture people with HIV. I think that's something that's important that at least I've personally seen and experienced just out in the world. So I don't know if anyone else wanted to comment on something that they have seen, whether it's an advertisement or policy or a billboard, something they've seen that kind of resonates with that.
So because this is a webinar, the audience can't.
Did you see that a question came in?
Yeah,
Question
if
came.
they can chat back. Yeah, so there's a question. How have changes in federal administrations affected the resources available to decrease the spread of HIV?
Mm.
You want that or you want me?
You can take it if you want, because you did a lot of the policy.
Sure, please on you.
Mhm.
I think this is an excellent question. I think that this is something that we talked a lot about as we were thinking about what is the future of HIV in the United States. And I think that who is in office makes a huge difference, right? I think that there are different agendas with regards to funding. There are different foci, right, that we can emphasize. And so I do think that we have seen shifts, whether it's an increase in allocation of resources or whether it's a change in even how we communicate. So, for example, in some administrations, we have highlighted the benefits of condom use, and in other administrations, we have talked about how they can be faulty and there might be challenges with the effectiveness of condoms. And so, I think that how we are able to articulate and then allocate resources is very much dependent on who is in office. And so I think that time will tell, right, when the November election comes, what we will continue to see with regards to HIV programs, initiatives, resources, and if we might then see a shift. Are we continuing to push forward federal projects and grants? Are we starting to shift more into grassroots and philanthropic agencies and organizations? I think that we have a strong enough foothold with regards to trying to prevent and treat HIV that it will continue to be prominent. The question is just where will our focus lie?
I also wanted to weigh as well on this question. Just bouncing off of what Dr. Oborn said, it's not just federal administrations that you have to keep in mind as well. It can be local or state elections. I think those are of equal importance, because like Dr. Oborn highlighted, is states may implement things, and then when we go to the actual county level where these initiatives might be very beneficial, they might not have the funding or might not have the policies that align with it. So I think that as much as federal administrations are important, and that definitely determines the direction that we see, it's also really important to keep your eye on these local elections and state elections, and state policies that may also impact different levels.
All right, so I'm going to ask one more question, then I think we'll wrap it up. So my question to both of you, because you have given this lots of thought. So what is your biggest concern about how we're treating HIV, and what your hopes be for the next 10 years?
Mm. Ooh. That is definitely a big question. Um, I I definitely think I'm very much a policy person. Um, and I really think that something I have thought of is, even if a policy might be passed that isn't related to HIV or related to certain at-risk groups, say it's a policy that might be like anti-trans, that might not target, say, gay men. Um, my fear is that these policies will have this kind of ripple effect, and that even though these groups aren't necessarily being outright targeted by certain policies, they will still feel that fear, that growing stigma, um, even though they're not targeted. And then what we might see a decrease in utilization of certain services, even though their access hasn't really changed. So my hope is that this is not something that will have as great of a ripple effect, or that there will be policies that turn that around, or the policies will fail. Because as Dr. Oborn talked about, there are so many advocacy groups out there that are just very, very vocal about policy changes, about resources, about safe spaces. And I think that those are going to be those grassroots nonprofit organizations are going to be really key for conquering HIV and turning that around.
I think that's wonderful, Brooke. I try to be an optimist as well, right? It's hard sometimes though when we're facing so many challenges. And when I think about the next 10 years or I think about the future, I think about how is it that we can continue to destigmatize? How is it that we can continue to really put HIV conversations in spaces and places that exist across an entire community? Right? Where it doesn't have to be exclusive of certain organizations that highlight infectious diseases or sexually transmitted infections, but how can we think about this as a broad sweeping public health issue that we're not kind of isolating, and continuing to think about how anyone can be touched by HIV, whether it's through personal experiences, through loved ones. And I mean, my hope is, of course, that we get to a point where we see almost no transmission, right? Where we continue to have either amazing treatment that minimizes the opportunity for transmission, or that we get some sort of, magic, right? Magic shot, right? If we get a vaccine, something that can help to minimize HIV from being a threat in future generations as well.
All right. Well, thank you so much to the two of you. This was wonderful. We are recording it, so we will post it on our website shortly. And I hope everybody on today will join us for our next webinar. We'll be looking at the 1990s on Hispanic health and aging. So thank you, everybody. Have a good afternoon. Bye-bye.